Hello and welcome to this OncLive peer exchange panel discussion titled An Evolving Treatment Paradigm for Hepatocellular Carcinoma. It's a very exciting time to treat patients with hepatocellular carcinoma with now 3 new FDA-approved beyond sorafenib and phase 3 trials showing unprecedented survival in the frontline setting. In this OncLive peer exchange panel discussion, we're going to discuss multidisciplinary management of advanced hepatocellular carcinoma or liver cancer. We'll take a detailed look at the new agents to provide you with practical perspective on the best way to use them while treating patients with metastatic disease. In addition, we'll look at the abstracts from the ASCO 2018 annual meeting and talk about how the new research will impact clinical practice. I'm Dr. Ghassan Abou-Alfa, and I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, associate professor at Weill Cornell Medical College in New York City. Participating today on this distinguished panel are Dr. Ruth He, Associate Professor of Medicine and Hematology Oncology Specialist at Georgetown University Medical Center in Washington, D.C., Dr. Mark Kowal, Clinical Associate Professor at Internal Medicine in the Division of Hematology Oncology and Bone Marrow Transplantation at the University of Iowa in Iowa City, Iowa, Dr. Mark O'Hara, Assistant Professor of Medicine and Attending Physician at the Department of Medicine at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. Dr. Manish Sharma, Assistant Professor of Medicine in the Section of Hematology Oncology and Associate Director of the Committee of Clinical Pharmacology and Pharmacogenomics at the University of Chicago in Chicago, Illinois. And Dr. Amit Singal, Associate Professor of Medicine, Medical Director of the Liver Tumor Program and Clinical Chief of Hepatology at UT Southwestern Medical Center in Dallas, Texas. Thank you so much for joining us. Let's begin. Well, I think it has been really an exciting year for HCC. I mean, not that long ago, probably even I would say 2 years ago, I would be in some social event and talking to a colleague and say, so what do you do? And say, I, for example, work in melanoma. And of course, exciting, what have we? We talk a little bit about this and that. And they look at me and say, so what do you do? I say HCC. And then the next question will be, great weather today. and then this year, to follow on that, I mean, no kidding, a fellow in training come into my office and say, I would like to consider doing my research with you. And my response was to him, I think you're looking for colorectal cancer next week. I said, no, I'm here for HCC. And whoa, I never had this before. It's incredible how much is going on. And if anything, really, probably the great news is for the patients. And no doubt that we are, all of us, involved one way or the other academically to get involved in taking care of patients with HCC. But I would say that in the community, there's more and more attention to the disease as well. And this is, of course, because of the multiple events that we're seeing in that disease. But with this said, let's start help each other and at the same time help our colleagues who are listening to us today or seeing us today. Is HCC is really rather foreign a little bit to oncology. And if anything, we many times we even get questions as simple as do we really need a biopsy or not? Because understandably, historically, we heard about the screening component that would really not necessarily require biopsy. And maybe, Amit, you can help us there because there's more from your field as a hepatologist. What's the story of screening and no biopsies in regard to HCC?
Yeah, so I think that, HCC is a cancer where we have a very defined high-risk population. So over 90% of HCC in the United States actually happens in the setting of cirrhosis, the end-stage component for any chronic liver disease. And so, we have a population which we can implement screening programs using ultrasound with a biomarker, alpha-fetoprotein. When you find this, you should then perform a 4-phase CT or a contrast-enhanced MRI. And because of the high risk of developing HCC in the setting of cirrhosis, which can extend anywhere from 2 to 6% per year, if you find a lesion, at least in a hepatologist's eye, it's HCC until proven otherwise. And so, when you have these contrast-enhanced imaging studies, if you see arterial enhancement and delayed washout, the classic criteria that we've been using for years, you can actually have, if you have those criteria, the chance of it being HCC is somewhere on the order of about 95 to 97% certainty. And so when we talk to when I talk to my patients and I say, we can say this with near certainty that this is HCC, the question is, do you really need to put that patient through a risk of a biopsy to confirm and to lower that risk, of having a false positive?
I hear your point, and I definitely hear the kind of historical background to the whole story. But Mark, you and I mean, we biopsy patients even before we apply any therapy. Why HCC will be different, or what will be your argument for HCC to biopsy?
I think there's a couple different points, but the first would be, sometimes while you might have some convincing evidence, if you have a LIRADS-5 or something on the imaging that sort of suggests that you definitely have an HCC, there's a chance that there actually might be a mixed picture of an HCC and a cholangiocarcinoma that may or may not respond to an HCC-directed therapy. You might be better off doing.
I see. So in other words, a biopsy is needed because simply you might not be even dealing with HCC alone, even though it could be HCC, as we heard from Amit, but could be also HCC plus cholangiocarcinoma, for example.
Exactly.